talk about the ventilator. Ventilators come in all sizes, okay? Today we're doing a real mechanical ventilator, full blown, but this also can act as a BiPAP too, okay? So, let's see what we're looking at. We put an artificial lung here. All you're looking at is this is the for instance, this is the end to the ET tube, for instance. From here on in is what's called dead space. Okay, you have an inspiratory and an expiratory flow. Just in case, all these machines are very carefully done, so their on switches usually are somewhere hidden, so you can't undo things. In fact, I can't even find it.
There's a power switch here. Is this it?
Right. So here's like they have a safety button like for the nuclear weapons. Now this is the kind of machine that when it starts making noise, it says, "Pay attention to me. Something's wrong." What this starts doing is it'll do an automatic checkup on itself. Okay, and calibrate itself. And it's at this point is when you call a respiratory therapist.
We take it apart, we throw everything away. As you can see, everything is disposable. That's a big issue with the government now, and the state, and OSHA, and they want everything, and
In fact,
Joint Commission, they want everything disposable.
right.
Tell them single patient use.
Tell them why.
Use.
Before we had water here, right?
It was water here, and there was a lot of contamination, and it was the patients were getting pneumonia.
And which bacteria loves water? Pseudomonas, Aeromonas, any of the monases. But the problem is, we just took away. But what else? I'm sorry. Go ahead.
So what we do is we throw everything away. Like I said, everything is single patient use. Then we have the wipes that we have, the disinfectant wipes that we have. We wipe it all down. It's got a 2-minute waiting period to dry. Once it's dry, they reassemble the unit, they connect it, and they do a quick SST calibration to make sure it's working properly before you place it on another patient. I have been filling these out, which is the cleaning and assembly of the 840 ventilator with all the checklist of everything that they checked on it, that it was calibrated, that everything was replaced. That ventilator serial number.
This machine is a life or death machine.
Yeah.
So it's like the OR. You got to have a check-off list. Make sure there's nothing going wrong. Was this checked? What the this, that?
Yeah, everything's monitored by OSHA, by the government, by Joint Commission. So it's all regulation issues, okay? So we put that ventilator serial number, that data was assembled, that therapist that assembled it. And then once we place it, we put on the patient that was placed on, the room number where the patient is at, and the visit number of the patient. That way we can track that particular patient, or we can even track a ventilator if there's any issue that is something malfunctioning in the vent, or maybe a contamination in the vent. We can track the patients that have used the same ventilator via the visit number and the serial number of the ventilators. We can keep track of which patients have been on which vent. If there's
Just in
any
case
issues.
we get VAPs, and all of a sudden we can isolate, hey, it happened to be VAP on this particular machine. Let's take it offline. It probably needs to be completely desensitized, polyculture it, and then we'll have it cleaned up.
So normally we do this with every ventilator, and we keep these in the department, in the log that we have, there. So these are the initial, when you turn on your vent, this is how it's going to show up. If you want to go into the calibration mode, then you have to press the button on the side.
You're not expected to do that. In fact, I'm glad he's here, because I'm going to show you how it happens. You're going to call me in the middle of the night. You're going to tell me what?
Which one? That the alarm is going off? Or?
No. I got a new patient from the ER. Got intubated for
Okay.
asthma or whatever. Tell me. I'll typically would tell
Well,
me.
we will call our doctor. We would tell him that the patient came in. He might have been intubated already in the ER because he came in distress. We'll give him the blood gases that were in the ER. What blood gas?
Okay,
normally
so
we do
I have not giving orders yet, but the patient got intubated. The ER doctors here can give orders, but as a respiratory therapist, he could intubate if he had to. Okay, he's the backup. And then what typically do you start a ventilator on?
We started in a safe mode. Normally we want to go with, depends if the patient is not alert and oriented. We start with AC mode, respiratory rate of 20.
AC mode, respiratory means 20. That the patient's minimum he's going to get is 20 breaths. He's going to tell you the tidal volume now.
Distress, so you want to,
Now, with AC, if the patient wants more, the machine will give him a full ventilator breath. You go above it, which you set, but never below it. Okay? Now, we want to get him off that method as soon as possible, because they can go into an alkalosis very easily. if they hyperventilate because of pain, temperature, etc. So what's your tidal volume?
And your tidal volume, start out safe tidal volume, I think is like 2 kilogram. Come on, two.
Well, now the new rules with the low volume is 6 mLs to 8 mLs per kilo of your ideal body weight. If anything, the bigger we are, technically the smaller our lungs is going to give us a higher pressure. And so low tidal volume, which leads to transpulmonary pressures or what's called the plateau pressure of 30 or less. He's looking at that's being monitored for you, or you can hit a button to see that.
Yeah.
As long as you're below 30, you can increase your tidal volume if you have to adjust the CO2, the pH, etc. Once you're above 30, you have to bring down the tidal volume. You got to give it more time for exhalation. And that's the treatment no matter what it's ARDS, CHF, pneumonia, is low tidal volume ventilation. We're avoiding barrel trauma. If this is my alveoli and I have little slits on it, as the smaller I keep it, the less leakage there's going to be no matter what type of edema. The minute I make it bigger, I'm going to make those slits bigger also. So it makes perfect sense. The only reason our volume got so high was the anesthesiologist wanted to avoid atelectasis. Like that was a big problem. To do that, what does this machine automatically do for you? Because do you know what you guys do every minute or two? 2 to 3 sighs. What is a sigh? Twice or 3 times your tidal volume. The machine every once in a while will give you a deeper so we can ventilate the lower lobes, don't get atelectasis. But now we've backed off. The whole thing now is 30. So think about it. 30 ejection fraction for an ICD, right? And 30 over here. Transpulmonary pressure. That's the pressure that the lung is seeing. Your transpulmonary pressure can never be higher than your peak inspiratory pressure. But the peak inspiratory pressure is not what the lung is seeing. It's always below that. So if your peak inspiratory pressure is at 30, you don't even have to measure your plateau pressure because it knows it's got to be less than 30. Okay? And we'll accept high CO2s. He knows that the pH is the key. As long as the pH is close to normal, that patient is well compensated. Okay? He's been doing it before we got. So he's not going to tell me the settings. So we 100% assist control, 20.
Yeah.
Tidal volume.
That's one of the things that they teach us, like in school. Start high with the FiO2. You start high and then you work your way up. Because if the patient's hypoxic, you can always, you start high and then you go fixing it. If he's hypoxic and you start low, you're gonna keep him hypoxic.
Now, let's
better
say
to go high.
Let's say that even if we knock him out completely, he's gonna get 20 breaths with the said tidal volume. Also, these machines are stupid, but they're also very smart. If this machine doesn't get a certain breath within 20 seconds, which is considered an apnea, it's going to kick in into a backup rate. Okay? And of course, it's going to our alarm. They're going to call him. The nurses immediately come over here. The first thing to check is anything disconnected from the patient? What are the pressures? Is the patient fighting the... Always look at the patient. Is the patient in distress or not? Okay? Is there a possibility of a pneumothorax? Is there a possibility that the patient's doing PEEP? Okay, or the intra-abdominal pressure that we had the other day, okay, bladder pressures for intra-abdominal compartmental syndrome. My diaphragm is not going to work as well, okay? So he most of the time he's going to tell me they are going to intubate with at least with a 7.5 or greater. Why? The endotracheal tube that he's going to use, if he intubates or the doctor intubates, should be 7.5 or greater. Why?
You don't want the tube to collapse.
No, you don't want the tube to collapse, but you want to be able to do a bronchoscopy if you had to and still be able to ventilate them. If it's a smaller tube, it's much harder. And you remember the radius and the pressure have to do with each other. Every time we decrease the radius by a half, what happens to the pressure? It goes up by 4 times. So we have resistance, we have flow. That's why these guys are so smart, because they understand pulmonary physiology.
Remember, it's like I told you guys in the intubation class that some of you went to. It's like breathing through a straw or a garden hose. Same thing. You put your patient through a straw, it's going to be harder to get them extubated. Harder for them to breathe, So it's the same thing. Just remember something like that. Breathing through a straw or breathing through a garden hose, which is better for you, Where are you going to breathe better? Where is it going to be better to suction? Because you got to get that ballard through to suction them out. So with that smaller than a 7, it won't go through. You're going to have to get a pediatric ballard.
So
So those are all
multiple
things to
reasons.
consider.
Also, you could dial in your FiO. We talked about PEEP. Minimum you said is 5 of PEEP unless the patient's super hypotensive. That's the backwards pressure. Keeps the airway open. You recruit more alveoli. We consider 5 physiologic. But if the patient's really blood pressure is low, you go to 0 because if not, it's going to the venous and it's squeezing out even more. So if you put your PEEP on and the patient drops their blood pressure, hypovolemia is one of the main causes. Okay, we're going to do a blood gas. We're going to check it. We're going to optimize then the blood gas to the pH, the PCO2, the standard therapy. Okay. Now the whole thing is we don't touch the patient. We're the biggest enemy because we're bringing infection. So these we used to switch on a daily basis. Now, unless there's a real good reason, they don't get touched. The less you touch it, the less infection. Okay? This, of course, is acting like the patient. We remove water from here. Now what we do is, through the endotracheal tube, there's a little piece of foam. It's brilliant. It becomes an artificial nose. So you do your own humidification
Right here.
with your own breathing.
Right here. This is the HME, heat moisture exchanger. It's right here. This is the one that goes there.
Before, without that, we had to be disconnecting, taking out the water that built up in the system, all that kind of stuff. On top of that, now that you're hooked up, we can do physical. I can tell you what the lung compliance is. What's the resistance? If my compliance goes up without my resistance changing, it's in my lung parenchyma. If my resistance goes up and my compliance doesn't, it's bronchospasm. It's inside the tubes. Like I told you, what we need to do is look at these machines and they talk back. They don't talk back in English. They talk back in medicine. You need to know what these are telling you. And listen to these guys because this is what they do. They drive this ship more than their car. Okay? And the thing is, he can take any car from any year and work it because he understands the system. This is a green hose behind it. What's a green hose? Connection to the wall for oxygen. The oxygen now can drive, you can dial in your oxygen, it also drives the aerosol therapy. Once again, in line, they don't have to touch the patient. You give beta 2s, LAMAs, you give steroids. I can give antibiotics, especially to whom? Cystic fibrosis, people with bronchiectasis, even pneumonia. Okay? You have to understand basically the output is just basic physiology, compliance, resistance, but we're just giving him the settings. He automatically now we have a protocol to start weaning the patient or working them off the ventilator. As soon as we can, we want the patient into some kind of pressure support mode, which means that you are going to breathe or the patient is going to breathe exactly how they want. All we're going to do is supply pressure assist. So if you want to breathe chain stroke, slow, fast, whatever, you'll be able to do it. Less sedation. If I do need sedation, we're going to use propofol. Anticipate that when you use propofol, has no anesthetic properties, so the patient is asleep but feeling pain. Okay, and the pressure may drop, which typically will respond to fluids. The minute you get propofolized, we're trying to do boluses instead of continuous infusions. The nice thing about propofol is it decreases intracranial pressure. The neurologist could come in, turn it off, and 2 minutes later, patient's back to, you could do a neurological exam. Okay? Just be aware of the pressure situation. And it's contraindicated if the patient is getting what? In fact, you got to turn this off. It's made out of lipid. So if the patient's getting lipids, stop the lipids while he's getting the propofol. No matter what happens, the patient gets what's called a spontaneous breathing trial every day because we cannot predict if the patient's ready to go or not. It's not a gut feeling only. So now, what did I tell you about a negative inspiratory force of 25? So it's called weaning parameters. If the patient's, or even on the machine, if you can pull a minus 25 during inspiration, it has been shown that you can extubate the patient safely, and there's never been an extubation failure. If we're going high risk, just work yourself backwards. Leave them on this with a BiPAP. You can use on and off, but that's too much touching. Okay? Take them off of this, switch them over to a BiPAP. Now we're doing a mask. We now back have our airway, the epiglottis. Aspiration becomes less likely. Remember, these patients should be at 45 degrees, decreased aspiration. Okay? What else? So we want to get, and you want to get the lowest FiO2. So we don't got extubation parameters. If you're more than 10 centimeters of PEEP, I can't extubate you. Why? It's hard for me to give you 10 centimeters of PEEP if I don't have you intubated. 5, no problem. Okay? But 10 is probably the max. And I can't give you, now that I can give you a BiPAP, I can maintain it. Okay? What else?
Question: PEEP does it keeps the alveoli from like collapsing or?
Right, here. You're going to do PEEP for me. Whistle.
I can't.
Yes, you can. Well, go like this.
Okay.
Look. Pursed lip breathing. Your cheeks went out. Why? Back pressure. This backwards pressure lets you exhale for a longer piece of time. Where do we have our obstruction? During inhalation or exhalation? During exhalation. We want that as long as possible. So that's why we want the bigger tube. Okay? But that back pressure, when you whistle, that is the back pressure. That's where the pink puffers, they do pursed lip breathing on purpose. They know it's just a natural thing that happens. What else? So usually assist control to SIMV with pressure support. Typical pressure support is 15. That's full mechanical ventilation. The only thing you need for that, though, that the patient has to be spontaneously breathing. If not, the machine will kick back into a backup. But then when you give them the pressure and the oxygen, the patient sets their own tidal volume, their own respiratory rate, and they're going to be the most comfortable they can be because they're breathing exactly how they want to breathe. We don't have to guess anymore. They can even have apneas without a problem. And by adjusting your pressure support either up or down, you can give the patient more or less tidal volume. PEEP is still adjustable. And the nice thing is, once you're down to an extubatable number, now we go to BiPAP. No, before it was completely to non-extubation. Now you could go to a backup and extubate people who are high risk, or you think it might be a high risk, and give yourself a backup. If anybody tells you they never had to re-intubate anybody, they're lying to you, or what they are is a new person because they haven't done enough. Okay? Just like when a surgeon tells you, I've never had a pneumothorax, he hasn't put any left CUP lines. Or he doesn't check his chest x-rays. Okay? So are we still afraid of the ventilator? If we do, okay, so what's compliance? What are we looking here? The change in pressure per volume. The more compliance, the greater the volume per pressure. Emphysema, less elasticity. The stiffer I make this, watch. Well, it's already in a procedure error, but there's no air being delivered. So this thing is going to kick up. See, it just went kicked up in the safety ventilator in progress. But if you want to know restriction, this is what restriction would feel like. Just put yourself in the machines. Put yourself in the machine's place. Okay? Going back to being normal. If I took away this piece of rubber, you become emphysematous because it becomes even easier to expand.